Well, hello, and welcome to Cases from the Community. Investigators discuss the optimal management of chronic lymphocytic leukemia. I'm Jeremy Abramson from Mass General Cancer Center, and I'll be moderating the meeting today. This is our faculty. As you can see here, we've got a terrific collection of friends and colleagues up here. I'm joined by Dr. John Allan from Weill Cornell Medicine, Dr. Bita Fakhri from Stanford University School of Medicine, Dr. Shuo from right here at Northwestern University in Chicago, Dr. Mazyar Shadman from the Fred Hutch Cancer Center in Seattle. And we have got a spectacular program for you today. I'm going to roll through all of our disclosures. Including Dr. Love's. And here's the commercial support for today. Research to practice, planning committee, staff, and reviewers have no conflicts of interest to disclose. This program will contain discussion of non-approved uses of agents and regimens. Please refer to official prescribing information for each product's approved indications. This is our program today on CLL. In order to make this meeting more relevant to attendees, Dr. Love interviewed 3 general medical oncologists, Drs. Susmitha Apuri, Stephen Fred Divers, and Priya Rudolph, who posed cases and queries on a number of key clinical issues. We're going to play video excerpts on a number of key clinical matters from those interviews, and they'll be featured throughout today's program. So this is where we're headed today. Dr. Fakhri is going to lead us off with continuous BTK inhibitor therapy. Then Dr. Allan's going to discuss first-line time-limited treatment of CLL. Dr. Ma will address management of adverse events and associated adverse events with treatment. Dr. Shadman will talk about sequencing of treatment in relapsed refractory CLL. And then I'll take us home with CAR T cells and other emerging novel therapies. So let's jump into it and ask Bita to get up to the podium and tell us about current and future role of BTK inhibitors in previously untreated CLL. Bita.
Thank you for that generous introduction. So I'll be talking about BTK inhibitor updates in frontline CLL. And my 2 major learning objectives are to discuss the trials that have resulted in the approval of covalent BTK inhibitors in the frontline and some relapsed refractory options. And then we'll switch gears and talk about non-covalent BTK inhibitors that have read out in phase 3 clinical trials. So it is known to this audience that the field of CLL has seen tremendous advancements in the past decade. And if I want to summarize the major updates in the past decade, it's the story of this slide. So I'm going to spend some time and just drive you from clockwise from RESONATE-2 trial, which was a randomized trial of ibrutinib versus chlorambucil in the frontline setting, with ibrutinib being the obvious, basically, winner. And after this point, when the field started gaining confidence about this molecule, ibrutinib, a covalent BTK inhibitor, the next rational step was to take this molecule and compare it to something real rather than chlorambucil. And that was the rationale behind the Alliance, Cooperative Groups Alliance and ECOG trial design. The Alliance trial compared ibrutinib-containing regimens versus bendamustine rituximab, which at the time was the standard of care in old and frail patients. And as you see, ibrutinib-containing arms were the winner. And ECOG did a parallel effort. In a parallel effort, compared ibrutinib plus rituximab to FCR, which was the standard of care in young and fit patient population up until this point. And based on these 2 pivotal clinical trials, the field of CLL in America left the chemoimmunotherapy behind toward the targeted agents. But we all know that ibrutinib was truly landscape changing, but it was associated with some very real side effects, particularly cardiovascular toxicities. So that created space for new generation BTK inhibitors to come into play. And at the same time, for the very first time, the concept of time-limited therapy was examined in the CLL14 clinical trial, where the combination of obinutuzumab venetoclax for 1 year was compared to obinutuzumab chlorambucil, which at this point was the standard of care in old and frail patients, with outstanding results of 6-year 53% progression-free survival. And this was pretty novel for the field. In patients who took the combination for 1 year, they enjoyed a 5-year treatment-free remission, and at 6 years, 5.3 out of 10 patients are still in remission. And then moving toward newer generation covalent BTK inhibitors, we will talk about the Elevate treatment-naive clinical trial, which was the registration trial for acalabrutinib in the frontline setting, followed by Sequoia, which was the registration trial for zanubrutinib in the frontline setting. So how I'm going to drive in the next few minutes. Most recent updates in continuous BTK inhibitor. We'll talk about the decade-long follow-up for the Resonate-2 trial. We'll talk about the Elevate treatment-naive Sequoia trial, and then we'll switch to relapsed refractory Alpine, which was zanubrutinib versus ibrutinib, and Elevate relapsed refractory, which was acalabrutinib versus ibrutinib. So the 10-year follow-up, at a median follow-up of 9.6 years, the median basically progression-free survival of Resonate-2 trial in the ibrutinib arm was 9 years, indicating if a patient is able to take their covalent BTK inhibitor in the frontline setting, they potentially can have a good decade of disease control. And here you see that the 5-year progression-free, the 5-year overall survival with both ibrutinib and chlorambucil is shown on the right side. So Resonate-2, the 10-year follow-up, shows a median progression-free survival of 9 years. And now moving to newer covalent BTK inhibitors. So the Elevate treatment-naive was a trial that randomized patients with treatment-naive CLL to receive acalabrutinib plus obinutuzumab versus single-agent acalabrutinib versus obinutuzumab chlorambucil. And the primary endpoint was PFS. And here you see that the 6-year progression-free survival was 78% in acalabrutinib plus obinutuzumab versus 62% in the acalabrutinib arm versus much lower, less than 20% in the obinutuzumab chlorambucil arm. And I want to emphasize that the trial was not powered to compare acalabrutinib containing arms. But here, everybody was surprised to see that receiving 8 grams of obinutuzumab in the acalabrutinib obinutuzumab arm in the beginning of the treatment 6 years later results in basically a 15-16% difference in progression-free survival. And if you look at the overall survival, you'll see that the overall survival in the acalabrutinib obinutuzumab arm was significantly improved as compared to the comparison arm of obinutuzumab and chlorambucil. And then many basically theories have come why there was any difference between acalabrutinib obinutuzumab and acalabrutinib single agent. And here you see that adding obinutuzumab results in faster and deeper remission in the beginning. So if you follow the blue line, you'll see that basically 3 months into taking obinutuzumab acalabrutinib, the CR rates are 95% as compared to 80% with single-agent acalabrutinib. And then 6 years later, the CR rates in the acalabrutinib single-agent arm, they continue to deepen with time, but they don't go beyond 90%, whereas in obinutuzumab acalabrutinib, they reach a 3-month basically CR of 95%, and at the end of 6 years, it's 96%. So basically, the take-home message is adding obinutuzumab does result in a faster and slightly deeper response. And I'm not going to spend so much time on the safety profile, but here you see that in terms of safety profile, the most common basically adverse events, particularly focusing on the high grade, were basically diarrhea and cytopenias. And if you look at the AEs of special interest, particularly the risk of atrial fibrillation with acalabrutinib, high-grade atrial fibrillation happened in less than 2% of patients, and high-grade hypertension happened in about 4 to 5% of patients with acalabrutinib. And then Sequoia was a 6-year follow-up. Sequoia had 4 arms, arm A, arm B, arm C, and arm D. I'm not going to talk about arm D, but arm A and B was zanubrutinib versus bendamustine rituximab, excluding TP53 aberrant patients, because we knew that it's unethical to give those patients chemoimmunotherapy. And here you see that basically long-term follow-up shows that the 72-month basically progression-free survival is about 75% with zanubrutinib, much less with BR. And if you look at arm C, which was a dedicated arm for TP53 aberrant patients, in this hard-to-treat patient population, the 6-year progression-free survival was 65%. And if you look at by IGHV mutation status, we know on the left side, in chemotherapy, patients with unmutated IGHV respond way worse to chemotherapy as compared to mutated. But even mutated patients who received bendamustine rituximab, as shown in the mustard line, they did inferiorly as compared to patients who received zanubrutinib. And if you look at the right side, you see that in patients with TP53 aberrant disease who got zanubrutinib, arm C, the IGHV mutation status did not affect progression-free survival. It's really hard to tell which one is mutated and which one is unmutated. And skipping through safety profile, as it's going to be covered, the ELEVATE-RR was a study of acalabrutinib versus ibrutinib in a head-to-head fashion. And the main take-home message was acalabrutinib is a better tolerated agent in terms of a lower rate of AFib, aflutter, and also a lower rate of hypertension. But in terms of the primary endpoint, which was progression-free survival, it's really difficult to tell which curve is which. So basically, in terms of efficacy, the two agents proved to be similar with an improved side effect profile favoring acalabrutinib. In a similar effort, the Alpine trial was a trial randomizing patients with relapsed refractory CLL who are BTK inhibitor naive to receive zanubrutinib 160 milligrams twice a day versus ibrutinib 420 milligrams. And this was the first study that the 3-year progression-free survival favored zanubrutinib, 65% versus 55%. And in patients with TP53 aberrant disease, this difference was more pronounced. So the 3-year PFS in the TP53 aberrant patients was 60% versus 40%. And if you look at the side effect profile, for whatever reason, COVID-19 was higher in zanubrutinib. Neutropenias was somehow similar between the two arms. Arthralgia slightly improved with zanubrutinib, and diarrhea slightly improved with zanubrutinib. Now, focusing on non-covalent BTK inhibitors, so covalent BTK inhibitors, they form a covalent bond between the drug and the C481 site, but non-covalent BTK inhibitors, they're more liberal in their action. They're bind, unbind, rebind. They don't necessarily require that strict shape of the receptor. So Bruin CLL 314 was randomization of pirtobrutinib versus ibrutinib in both treatment-naive and relapsed refractory patient population. And then patients were stratified based on TP53 and prior lines of therapy, with the primary endpoint of non-inferiority of overall response rate. And here you see that the overall response rate with pirtobrutinib was 87% versus 78% with ibrutinib in the intent-to-treat population, again, meeting its primary endpoint with an improved side effect profile favoring pirtobrutinib, particularly if you look at the AFib. The high-grade AFib with pirtobrutinib was 0.9% versus 4% with ibrutinib. And the Bruin CLL 313 trial was pirtobrutinib versus chemoimmunotherapy, bendamustine rituximab. And here you see that the 2-year progression-free survival was 94% versus 70%, again, making the trial meet its primary endpoint of PFS superiority. And similar to CLL 314, an improved safety profile when compared to chemoimmunotherapy, speaking to the fact that pirtobrutinib is a pretty tolerable BTK inhibitor. With that, I'm happy to go through the cases.
Great. Thank you, Dr. Fakhri. And now we're going to go to a video with some cases. We're going to start out with a case with Dr. Rudolph, who was interviewed by Dr. Love.
Good evening, everyone. In our unique Cases from the Community CME format, we enlist community-based general medical oncologists to meet with me and present real cases from their practices for input from the faculty. Tonight, Dr. Susmitha Apuri, Fred Divers, and Priya Rudolph present cases of CLL, beginning with Dr. Rudolph, who cares for a 79-year-old woman who she's been observing off treatment for 8 years, but now has progressive and rapid lymphocytosis and lymph node enlargement.
I had struggled with whether or not I should start her on treatment. My reason to start her on treatment was entirely based upon noticing an increase in tempo of her leukocytosis and lymphocytosis. I was curious to see if investigators use the tempo of leukocytosis, lymphocytosis as a reason to embark on treatment. Likewise, as far as lymphadenopathy, is there a size of lymph node that would trigger you to start treatment? Or are you looking for doubling of the lymph node size within a 6-month period? If this patient had deletion 17p or TP53 with her current clinical scenario, would that have prompted earlier treatment from an investigator standpoint? She was started on treatment with zanubrutinib. She had excellent response. She had an initial significant further rise in her white count as expected. It went as high as 250,000, followed by gradual decline of her leukocytosis and lymphocytosis. She has had no toxicities from treatment. She's been on treatment for 3 years now.
Any questions for the faculty?
I look at zanubrutinib and acalabrutinib from an efficacy standpoint to be very similar. Outside of comorbidities related to toxicities, are there any other reasons for choosing one over the other?
So Dr. Rudolph raises some important questions. Dr. Allan, let me start with you and say, when you're deciding to treat a patient, let's say you've got a completely asymptomatic patient, do the kinetics of the lymphocytosis prompt you to think about starting treatment?
Yes, so it's a great clinical scenario to question that, because our guidelines, the IWCLO guidelines, which we are typically following as treatment initiation, do include a doubling time as an indication for therapy. Many times these patients are completely asymptomatic and actually feel fine and have no problems, and you're watching this count rise and you're telling them, it's maybe getting time. With that said, I think, I still hold off many times until I really prove to myself that this is moving forward, there's a clear trend, and it's not really going to turn around. And what comes into play with that is some other molecular features too. If you see high-risk disease with deletion 17p complex karyotype, a Notch1, something like that, and you really start to see the white count taking off on you, I do think about treatment for these patients, and I do frequently initiate treatment even in these asymptomatic states. Not necessarily if a white count's jumping from 20 to 40, but once you start to really see a trend and you're now approaching 100,000, it's only a matter of time that these other absolute overt indications are going to come into play. And, that may be 6 months from now, and in the big scheme of things, starting that patient on treatment, because there is a risk for some of these high-risk patients to actually transform during periods of observation. And I believe, and I think there is some data to support that we may be able to prevent some of that by knocking down the clone and stopping that proliferation. So
I think, Dr. Allan, I think you make an important point that, it's the consistency that really matters. We know that CLL can wax and wane. A CLL patient gets a viral infection, their lymphocytosis will shoot up and double. That doesn't mean it's time to start treatment. We're really looking for steady trends that is putting a patient at risk for causing these indications, these more bona fide indications for therapy. Dr. Ma, how about when we think about nodal size, splenomegaly, when do those force your hand in treatment?
So I think it's very similar that some patients can actually present initially with the diffuse adenopathy, but if it progresses very slowly, it's not necessarily indication for treatment unless it's bulky and it's causing impending compression symptoms or cosmetic concerns. But if patients starting to have adenopathy that's progressing rapidly, I think that's definitely an indication for treatment. So not an absolute size necessarily, but it's more a matter of the bulk and the pace.
Now, how about molecular features, Dr. Shadman? So if you've got a patient who has a 17p or p53 mutation, will you treat that patient earlier than a patient without a high-risk cytogenetic change?
The short answer is no. That is not currently supported by the one prospective trial that we had from the German group that looked at high-risk patients, including those with p53 aberrancies. And when they looked at ibrutinib versus placebo, there was no overall survival, which is the only relevant endpoint in this setting. There is, of course, the ongoing SWOG trial, the EVOLVE 1925, which is looking at same question for patients with high CLIP score or complex karyotype, looking at when soon or early versus late, and we're waiting for the results. I agree with John that there are very specific scenarios that we may think about starting treatment, and that has to do with a combination of having high-risk features, including p53 aberrancy, but more importantly, unmutated IGHV and some of the stereotypes and Notch1 mutation. But that's a very, very small group of patients. So in general, I would not use p53 status as a reason to start treatment. Great.
And Dr. Fakhri, Dr. Allan is a new father as of 5 months ago, and it raises the question of if you're a parent of which one of your children is your favorite, right? So let's think about that when it comes to BTK inhibitors. Do you have a favorite next generation BTK inhibitor, and how do you choose between acalabrutinib and zanubrutinib?
Yeah, I mean, that was a perfect analogy. So I honestly will just discuss with patients that if someone has TP53 aberrant disease, just because the Sequoia trial had a smart design of having a dedicated arm for TP53 aberrant patients and generating data, I'm more comfortable using zanubrutinib for TP53 aberrant patients. And that being said, anecdotally speaking, I have patients with TP53 aberrant disease on acalabrutinib who are doing really well. And in terms of side effects, so zanubrutinib, we know that has that late toxicity of hypertension. So if someone has multiple cardiovascular toxicities, comorbidities, I discussed the potential for developing hard-to-control hypertension. Zanubrutinib is associated with a higher rate of neutropenia, but in general, very well tolerated. And on the other hand, acalabrutinib is associated with headaches that are self-limited. It takes 3-4 months for patients to get through them. But if someone has lupus with basically neurological features or really bad migraines, I tend to avoid acalabrutinib. So short answer, TP53 aberrant. Just because there is more data, I'm more comfortable using zanubrutinib. If someone is starting with really low counts, profound cytopenias, it might be harder to tolerate zanubrutinib because of neutropenia. And headaches that are hard to tolerate, I tend to avoid acalabrutinib.
Great. And we're talking about acalabrutinib and zanubrutinib. That was most of the data that you presented, most of what we'll be talking about today. Does anybody see a role still for ibrutinib that ushered in this era in the first place?
I would say just massive respect for the molecule.
Massive respect for leading the charge. But for toxicity reasons particularly, really we've moved with that proof of principle to zanubrutinib, acalabrutinib, and obviously now to non-covalent BTK inhibitors emerging that we're going to hear more about as our evening unfolds. So with that, let's invite Dr. Allan to the podium. John's going to talk to us about available and emerging approaches to time-limited therapy in the frontline setting.
All right, thank you, everyone. So we are going to look at some of these emerging time-limited fixed duration approaches. And here are some of our learning objectives. We want to incorporate some of this long-term data with upfront ven-oben, which was our standard bearer for our initial fixed duration approach. We want to look at some mechanistic rationale of combining BTK inhibitors and BCL2 inhibitors. We want to look at that efficacy and safety data that has recently been released from the CLL17 study, which is our first real modern era study that all comparators are going to be looked at against. And look at those published findings from phase 3 Amplify, and then identify other combinations with sonrotoclax and some of the other drugs in development. So here are our shifting trends. Obviously, we have treat to progression that we just talked about, but now we have in our NCCN guidelines, as well as approved combinations, we have fixed duration approaches, but also MRD-guided approaches that are recommended and have some utility in certain scenarios. Obviously, pros and cons of these, we've discussed those, and I'll leave these just here for you as a reminder, but we're used to what those pros and cons are, and it's this complicated discussion to start to have with your patient to make the right decision. When you look at CLL14, which put ven/oben as our kind of our standard bearer, like I said, fixed duration approach in 2019. That's when we started to really roll this out and use it. We have 6-year data. We're going to potentially see longer term data in congresses coming up, but we have PFS data that at 6 years has been met. And Dr. Fakhri just showed you ibrutinib has a 9-year median PFS, but here we're seeing a median PFS of around 6 years. So fixed duration approaches, when you relieve pressure, do seem to have shorter progression-free survival, but we've never really demonstrated that shorter PFS actually translate into a shorter overall survival, which actually is what matters. And we think we can treat patients, and all the pros of getting off of therapy are positives and toxicities, expense, all these types of things. But you will expect to treat your patient a little bit sooner, likely. On the other side, if you can get MRD negative, you can see you can really improve those outcomes. And with a regimen like Ven/O, you can get 75 to 80% of patients plus MRD negative. And that translates into a significant period of time off of therapy. What do we do with those MRD positive patients? We don't quite know yet, and they do present a problem for us to know how to optimally manage them. But nonetheless, thankfully with this regimen, like I said, 75 to 90% of patients, depending on the age of the patients that you're looking at, will get to this endpoint. On the bottom, you can see we have now independent predictors for who are going to have those inferior outcomes in terms of progression-free survival. We have disease bulk, unmutated IGHV, and deletion 17p. And actually on the right side from these updates, we see that complex karyotype is identifying an inferior survival when you're using a fixed duration Ven/Oben. And so I think we can still potentially optimize these patients and as a group that we need to look at in longer term studies like in CLL17, et cetera. The mechanism rationale for the two drugs, that Ven/O is a BCL2 and an antibody combination. Well, antibodies have issues, IVs, tumor lysis, infections, infusion reactions, there's logistics, it adds problems to the regimen. And so it'd be nice to get an all-oral approach. And so we have BTK, BCL2 combos, and they synergize. We have a lot of preclinical data showing it shifts BCL2 reliance. It actually causes egress out of the lymph node niche where the BCL2 can really hit them in the peripheral bloodstream and knock down these cells. And so there's a lot of mechanistic synergies that have been realized now in the clinic, and we are seeing the safety and efficacy of these combinations, and that was built on a lot of preclinical work and then clinical work. And so now we saw CLL17 to kind of put this all together. So what is the best approach for our patients? Is it a continuous therapy? Is it a Ven/Oben fixed duration? Or is it our now new modern, or not modern, but newer approach for a fixed duration with a oral BCL2 BTK combination? So this is CLL17 looking at ibrutinib, Ven/O versus venetoclax ibrutinib. The two fixed durations are in the standard cycles that we've seen, 12 cycles with Ven/O and the 15 cycles with the 3-cycle lead-in of the BTK plus the 12 cycles of the combination. This was at ASH as a plenary, and this was a PFS primary endpoint. We see here on the left side the final restaging response rates. You can see response rates look pretty good across the board. At a 3-year time point, we don't see the CRs really meeting there. We know at 6 years we can get up to 20, 30% with continuous therapy BTK inhibitor, so that will continue to improve. Any Ven approach typically has a CR rate of about 50%. We haven't really been able to eclipse that, even with triplet therapies, et cetera. Most of these patients have these 1.6 to 2 centimeter lymph nodes at the end of treatment, and they get registered as PR, even though they might be very deep MRD negative. On the right side, you do see some differences in activity of the regimens. I think we had a hope and a realization or a hope that oral combinations were going to be as effective at getting MRD negative as our antibody-containing BCL2 combinations, but with longer-term follow-up, and we have this realization that those synergies may not be as strong as we had hoped for, and so you can see the ven-oben on the left, having, again, 75+% of patients getting there in the peripheral blood, which is most of the landmarks that we're looking at. With the ven-I or ibrutinib combo, only about 50% of patients are getting there in the peripheral blood. And then with continuous therapy BTK, we don't expect patients to get MRD negative. We're not stopping this treatment. It's shutting down proliferation. And slowly it does kill these cells off. But at 3 years, you really don't get people MRD negative. You need almost 6, 7, 8 years of continuous therapy to get them there. But at this point in time, at 3 years of follow-up, mind you, only about a year and a half off of therapy of the fixed duration approaches, there is actually no difference in outcome depending on the approach that you have used for all-comer CLL patients. That's on the left side there. And on the right side, again, no overall survival difference either at this time point. Will this change over time as we get 6 and 10-year follow-up of this data? I suspect so, but this is kind of proving and solidifying, to me, this solidifies a fixed duration approach for our patients. You could also look at it on the flip side saying, well, continuous therapy looks just as good and these new regimens aren't as good or better, and I like what I'm doing. And that's a very valid and fair assessment as well. But I think many patients, particularly our younger patients, want to get off of therapy, and I guess this is kind of proof in that principle that we can, in fact, do that and keep them at the same outcomes. We are now starting to see, though, with fixed duration approaches, like I said, unmutated IGHV, deletion 17p patients, at the 6-year follow-up, we saw that they were having inferior progression-free survival. And on the left side, you can see the unmutated patients are maybe starting to show a little bit lower of a progression-free survival. It's not technically statistically different at this point in time, but with further follow-up, these curves may continue to separate. On the flip side, low-risk patients can do very, very well with that antibody exposure and have actually the highest PFS rates if the ven-O in low-risk disease. On the right side here, you see the deletion 17p high-risk patients. Again, the same story being told. Those fixed-duration approaches are actually having a less impressive progression-free survival, comparatively continuous therapy, but again, no overall survival difference. We're not necessarily doing harm to any patient by giving them a treatment. Maybe they're off 3 or 4 years. There's still some positives there, and at the end of the day, we can probably retreat them, rescue them, and they're going to still be alive 10 years later, living healthy, happy, and productive lives. When you look at safety, actually, the regimens are pretty comparable with the antibody-containing treatments. You have increased cytopenias, neutropenia particularly. With IV, you see pretty much similar across the board with AV, ZV, IV, similar rates of grade 3, 4 neutropenia, but less than any antibody-containing regimen. Ibrutinib, we don't see a lot of that at all. Obviously, these are ibrutinib-containing regimens, so we do see some AFib here. I think that goes away, and we'll see in the amplified data that that goes away. Infection rates look very similar across the board as well, but when you look at grade 3, 5 infections, when you introduce that antibody, just yet another data set that shows the antibody does increase grade 3, 4, and 5 infection rates, and actually in the ven-O, it was a little bit hampered by that, particularly with COVID and other infections going on. So it is something we have to contend with, and is a reason to potentially move away from an antibody-containing regimen if your patient is someone who is very immunosuppressed and already having issues with infections. So Amplify is coming around, and we've been looking for that perfect study, and we haven't had one because CLL fell short because it didn't have a triplet arm, basically. This study falls short because it has chemotherapy in it and it doesn't have a continuous therapy arm, and it doesn't have a ven-O arm. So no study has been perfect. We're trying to have to extrapolate each arm from certain studies and kind of do these cross-study comparisons. But Amplify looked at AV versus AVO versus chemoimmunosuppression. chemoimmunotherapy. This was reported 2 years ago, actually in February, is now FDA-approved approach for AV. And so here is that data. This was a primary endpoint. It was progression-free survival. It was powered to look at AV versus chemoimmunotherapy. The AVO versus chemoimmunotherapy was a secondary endpoint, and it met its primary endpoint. AV beat FCR-BR at the 3-year time point. You can see here 76%. AVO, though, is looking better. Just like AO looked better than A, we are now seeing AVO look better than AV in terms of progression-free survival. So there is some benefit to the antibody introduction into the therapy, but it comes at a cost of some toxicity. And so when you start to look at who might benefit from maximal therapy, you do see those patients with unmutated IGHV. Almost all of the benefit is restricted to them getting the triplet therapy. Those patients on the right side with lower risk mutated IGHV, you can see AV does just as well as the AVO at this follow-up at 3 years and even beyond as you look at those curves. And so maybe these low-risk patients don't need this maximal therapy. We can spare them a lot of the toxicity, and maybe there is a benefit for a higher-risk group of patients to get a maximal therapy if we think it's right and appropriate. But at the end of the day, again, no overall survival differences really are being shown by these different groups, and at least in the AV groups. And so do we need to maximize therapy? I think that's the question that we all have. What is our drive to maximize that first PFS, and I don't think it's necessarily an answered question at this point in time. When you look at the toxicity, again, antibody-containing regimens have increased neutropenia. You could see 46% grade 3-4 neutropenia in the AVO arm compared to 30% AV, similar to what we saw with IV and CLL17. The infection rates, another 10% increase in grade 3-4 infections, but all grade infections look kind of similar between the arms. And so these are things we need to contend with and watch and monitor. But now using a second-generation drug, the AFib, and those cardiac issues go away. The FDA approved this AV regimen for CLL in February, and so it's now out there easily to be had. You do 2 months induction acalabrutinib followed by 12 cycles of acalabrutinib venetoclax with the ramp-up of a ven in cycle 3. AVO is not technically an approved approach. It is in NCCN guidelines and is something to consider for the right patient, but just keep in mind this is where the approval kind of indication is there. Now, Sequoia Arm D, this is looking at zanubrutinib with venetoclax. This is looking at high-risk del-17p patients only, and then they opened a second kind of additional cohort within this arm to look at all comers. This is a response MRD-guided approach, very strict cutoff to stop treatment, multiple MRDs negatives with 2 bone marrow biopsies that were MRD negative, at which point you can stop treatment. All patients essentially got 2 years of therapy, and then maintenance if you were not MRD negative. Here, 50% CR rates in those ven-based arms. We see the deepening of MRD over time. So by the 2-year time point, we get about 60% of patients in the peripheral blood MRD negative. Though early time points at the 1-year time point, we're not quite getting there. It's again about 30% of patients, similar to what we saw in the Amplify study. Not too many people met the strict criteria to stop therapy on this, and so many of these patients, in fact, did get maintenance. But when you look at this combination, particularly the fact that half of these patients had deletion 17p, you can see these progression-free survivals are pretty impressive at a 3-year time point, about 87, 88, 90% progression-free survival, whereas the other true fixed duration approaches were in that 75% range when you look at kind of cross-study comparisons. So an attractive option, it's a lot of therapy. Maybe you're not stopping a complicated approach, but there's data out there to support it, and it is in our NCCN guidelines. Safety, again, second-generation drug. We see BTK inhibitor class effects, etc., and not really anything too surprising here and very similar. This is the last slide. And so we do have an additional BCL2 inhibitor that we are going to be hearing about, sonrotoclax, and there has been some combination studies with zanubrutinib, and there's a big phase 3 clinical trial, zanubrutinib sonrotoclax against Ven-O. It's the Celestial study. It's been accrued. We have not seen any data from it, and we eagerly await what that looks like. But what what I want to point to is that sonrotoclax is showing maybe a differential ability to attain deeper and higher rates of MRD negativity, as we're seeing these numbers with just all oral therapy push 80 to 90% of patients getting their MRD 4 or greater. So I'll leave this here. I know we're a little bit behind, and I'll give it over to Jeremy, and we'll go to the cases.
Thanks, John. So let's go to some cases. Let's go back to the community, and we're going to hear a couple of cases, first from Dr. Apuri and then from Dr. Divers.
The choice between indefinite BTK therapy and time-limited treatment, including venetoclax, changed dramatically at the 2024 ASH meeting when the Amplify data were presented. Dr. Apuri has an 82-year-old woman who preferred this strategy.
She was diagnosed more than 15 years ago and only under surveillance. More recently, in the past 9 months, I have noticed that she has become progressively anemic. She always had palpable cervical lymphadenopathy, but I have noticed that she's starting to develop axillary lymphadenopathy. She was reporting some lower abdominal pain that led to a CT scan that showed splenomegaly. So we did discuss that there are multiple new treatments that are now approved for CLL. I did offer her the combination of acalabrutinib and venetoclax. She started the BTK inhibitor, and the plan is to add venetoclax when we get there, which is, cycle number 4. I have seen an elevated uric acid on her just with the acalabrutinib. We do have a set protocol where we draw the uric acid levels every week while we are doing the ramp up of the venetoclax. I would like to know what they would do. Like, do they bring these patients into clinic and hydrate to IV hydration on a weekly basis? Have they been in any scenario where they have to do rasburicase on an emergent basis? I think a bit of the challenge with the oral medications is they are taking them at home, and even though we are seeing them, we are not really spending time with them per se in the infusion room. So sometimes that becomes a challenge where we are not picking up the subtleness of any abnormality that's coming our way.
So let's think, Dr. Ma, if you've got this patient, you're already starting the acalabrutinib, you're starting to see some hint of tumor lysis. How do you monitor these patients in clinic as you initiate the acala and then eventually bring in the ven?
So tumor lysis is relatively rare with the BTK inhibitor alone. So in this pre-treatment phase with the BTK inhibitor alone, we don't typically see too much incidence of tumor lysis. But nonetheless, since you're starting a new treatment, I typically would have patients do weekly blood works for the first month, just to make sure there's no unexpected hepatotoxicity or tumor lysis or cytopenias. And then if they're tolerating well, then on the ongoing basis, they could be monitored every few months. But then when you're actually starting the venetoclax, that's a different story because we all know venetoclax, one of the main issues we need to be careful about is the risk for tumor lysis because of the mechanism of action. It turns on the apoptosis machinery. Tumor killing can occur within a matter of hours. Actually, one of the slides in my talk will be addressing this point. So it's critical when we're doing the venetoclax ramp-up to monitor for tumor lysis labs. And I'm going to actually talk a little bit more details about how to monitor that. So this is actually a great question leading to that. But the risk of tumor lysis is primarily within the first 24 hours of starting a new dose during the dose ramp-up. Once you ramp up to the standard dose, then there's really very little risk of tumor lysis after that.
Now, Mazyar, I think folks are very used to the obinutuzumab venetoclax. They get a few doses of obin, you cytoreduce, you bring in the ven. Their white count is usually nice and low. How is it different in your practice when doing acala-ven? You haven't just cytoreduced with the obin.
That's a great question, and I think one of the unique features of A plus V is that, first of all, in this study, the acala was given for 2 cycles, and then ven was started, and I would say I've never done that in my practice. I just take my time and continue acala until the risk of tumor lysis is really low. Because at 2 months, many patients still have lymphocytosis related to acala, and actually some of the low-risk patients can be moved to the intermediate risk. So that flexibility, actually even beyond the TLS reason, many patients actually want to start treatment and then take care of some of their plans and come back 3-4 months. And I think that's a very nice feature. We didn't have that. I guess we didn't maybe think about it with obinutuzumab, but very commonly I add venetoclax in 4 or 5 months when the risk is low, and then I don't have to be super concerned about the monitoring and the risk of TLS.
And are there scenarios where you would use resveratrol? The question came up in the last case.
I definitely not in the outpatient setting. I don't remember having to do that. And even with obinutuzumab, the risk of tumor lysis, at least for the lymphocytosis, is very low. I would say with the pre kind of treatment and monitoring, that's rarely, and I don't recall having a patient who needed that, but definitely an option.
And Bita, we've talked about tumor lysis, but we've also heard there are other side effects that can occur with these regimens. So if we think beyond the risk of tumor lysis, how do you think about managing adverse events for patients who are getting a BTK inhibitor and venetoclax versus one of those regimens alone? Does it change substantially for you?
So just more frequent clinic visits and just reassuring the patients that the majority of these side effects will be completely resolved once the treatment has concluded. But, we can see more cytopenias, the risk of cardiovascular side effects is very real, even with time-limited therapy. So just, establishing realistic expectations and having patients come see, their physician on an interval that feels safe on both sides.
And Shuo, we heard a little bit from John about thinking about the OBIN and the relative value of that. So I'm curious about your thought. Acalabrutinib versus acalabrutinib obinutuzumab. Who do you choose to give the extra IV infusions to and why?
So as we have seen from the data, that the efficacy adding obinutuzumab definitely has convincingly increased the progression-free survival. In particular for the high-risk patient, like the IGHV unmutated patients, it has shown pretty big difference. So if there would be a patient, that probably would be the group of patients I would consider, even though I think with the AV alone, most patients do respond pretty well. On the flip side, the toxicity, of course, you have to take into consideration. So definitely there's an increased risk of infection. And especially during the COVID era, there's increased risk of COVID-related death in the AVO arm compared to the AV arm. So you really have to balance out the potential benefit of efficacy versus the risk from the safety.
Yeah, I think it's actually striking the amount of increased infections you get with the obinutuzumab when acalabrutinib is actually pretty great therapy. Let's go to another case. Dr. Divers and Dr. Apuri now.
Patients with CLL often end up starting treatment when elderly, which may require careful consideration of the baseline health of the patient. Dr. Divers has a 70-year-old man, and Dr. Apuri, a 75-year-old man, who exemplify the challenge that often presents.
This gentleman has a lot of comorbidities. He had significant diabetes, vascular disease, had an ankle fracture, was in an orthotic boot. He had a superficial bladder cancer. He's had a chronic biliary restriction with pancreatitis and an indwelling biliary drain. And someone found a CT that showed some mediastinal adenopathy while he was hospitalized with pneumonia. He had a leukocytosis at the time with a mild lymphocytosis. We did some biopsies, which showed CLL. His FISH panel was normal. We treated him with zanubrutinib single agent. He had a very rapid response in less than 6 weeks with his mediastinal adenopathy, and his leukocytosis and lymphocytosis resolved. And so I think the main question for the faculty is, a lot of these CLL patients are elderly and frail and have comorbidities, but, how do you decide single agent versus combination therapy? And if so, which agent would you pick based on any clinical or pathologic factors?
He's a 75-year-old gentleman who presented with progressive lymphocytosis, thrombocytopenia, and night sweats. He was symptomatic. However, he did have significant ischemic cardiomyopathy. What do you do with these patients? He had myocardial infarction many years ago, but unfortunately, he also had multiple PCIs, cardiac interventions, recurrent shortness of breath, and most of it was thought to be, because of his cardiac history. This gentleman, per se, had an EF of 40%. at the most recent echo. So he really has a good performance status, but with a low ejection fraction.
So John, how about it? Most of these patients with CLL are older. They're often frail. We heard about all these comorbidities. That sounded very familiar to all of us, I think. So how are you deciding between a continuous BTK strategy versus a time-limited strategy that includes a BCL2 inhibitor?
Yeah, I think I agree with that that patient with those types of comorbidities. There's probably going to be issues just outside of the drug that they're choosing, just issues getting to the clinic and the monitoring and all these other issues that they may come into play to where a combination approach might be difficult and complicated. And I think many of these types of patients, it is easiest to just use a continuous therapy BTK inhibitor, and they are going to do phenomenally well and actually tolerate it pretty well. On the flip side, though, you might say, well, they have a lot of comorbidities, and maybe there is a benefit of getting off of treatment. And if you can kind of give them 1 year of therapy, they may have several benefits where CLL is not their problem, the drugs we're giving them aren't their problem, and these other comorbidities that they're dealing with can be handled in absence of the drugs that we may have to hold because of a procedure or a biopsy or surgery or an infection or some other issue. And so, there's two sides to the coin, and I think you need to really think about the patient, their ability to remain compliant with the approach and remain safe during a ramp-up period and being able to get to clinic and to monitor, for the cytopenias and the infections and things like that. So, but in general, I think with these types of older patients, in my practice, typically age is a factor that, while it is just a number, many times, even if they are kind of a healthy 85-year-old, they themselves kind of just say, you know what, it's easiest for me to take this medicine. I'm in New York, and I know a lot of people are going back and forth from Florida and things like that in the wintertime, and so they are not available for an antibody. They're not available for a ramp-up. And so sometimes it is just easier to do this. So I think it is a difficult question to answer. It is always case-specific, but in general, for these older, higher-risk comorbid patients, typically a monotherapy BTK inhibitor approach is, I think, what we're probably most doing up here.
So that raises the question, and maybe I'll take this to Shuo, is, sometimes these older, frailer patients, we're going to prioritize a continuous BTK. It's easy. You don't need the IV infusions. Who do you not want to give a BTK inhibitor to?
Mm-hmm. Yeah, that's a very good question. So I think that's pertaining to probably several things. One is you have to think about the risk of BTK inhibitor, especially the long-term BTK inhibitor. As we know, the most concerning risks are bleeding risk, cardiovascular risk. So actually, that will be also discussed in my talk coming up. But if a patient is, for example, taking certain antiplatelet agents, for example, those patients who are taking dual antiplatelet agents after having cardiac stent, so typically we would recommend not to use BTK inhibitor in those patients because having 3 antiplatelet agents altogether has substantial risk of bleeding. Warfarin is another thing that we should avoid to be concurrently used with the BTK inhibitor. And then for comorbidities, cardiovascular, if patient has significant cardiovascular disease, in particular, patient who has significant structural heart disease, congestive heart failure, those who has reduced ejection fractions, those who has some valvular disease, which are making them at higher risk for developing cardiac complications. So those are the patients you may have to think really careful about committing them to a long-term BTK inhibitor.
So let's give you a real case, Mazyar, and we'll take it right from the interview. You've got this patient with ischemic cardiomyopathy. They've got an EF of 40%. They also have atrial fibrillation, and they're on apixaban. They need treatment for CLL. What are you going to do?
Well, so I think there are specific maybe scenarios at that. So ischemic cardiomyopathy that is treated versus untreated are very different, right? So if somebody has a history of it and it's now treated, and as long as they're not on more than one anticoagulant or antiplatelet therapy, I would be comfortable starting a BTK inhibitor. I do not start or use BTK inhibitor in patients who are on more than one blood thinner, a combination of an antiplatelet therapy and a drug like DOAC, as you mentioned. However, many patients who are on drugs like clopidogrel or aspirin, they actually don't need to be on it. I mean, the stent was placed years ago, and you call the cardiologist and they can stop. For an untreated ischemic heart disease, I would be worried about it because there's a risk of ventricular dysrhythmias, and so that's a different scenario. AFib should, in my opinion, never be a contraindication to use a BTK inhibitor as long as it's well controlled. And I would use BTKIs in combination with DOAC. Which one is better? We don't know. APIC7 seems to be, based on some kind of retrospective data, have maybe a better safety profile. We are looking at that with a number of institutions, hopefully for upcoming meetings. But I think in general, having a cardiologist involved when there's any question, I think it's important, especially with the borderline ejection fraction. And most of the time, you're able to start and continue with their help.
And Bita, we've got all these different drugs, and we think some side effects are drug specific, some are class specific, the classic being the headache with acalabrutinib. But in terms of the bleeding, in terms of the atrial fibrillation, cardiac dysrhythmias, do you notice or view there being a difference between acalabrutinib and zanubrutinib? And we can complicate matters and throw in pirtobrutinib as well.
Yeah. So in terms of AFib, just acknowledging cross-trial comparison is fraught with bias, but at least, it shouldn't stop us from thinking. So we know that the rate of AFib is slightly higher with acalabrutinib, and among the covalent BTK inhibitors, zanubrutinib has the safest cardiovascular profile. Pirtobrutinib, the rates of AFib are even lower, but unfortunately, when it comes to bleeding, even our non-covalent BTK inhibitors like pirtobrutinib, the high-grade, risk of bleeding is similar to covalent BTK inhibitors. So if there is a place for using pirtobrutinib in the future as frontline, I think it's for that, octogenarian or, patients in their late 80s and 90s who we know, they're going to need one line of treatment, and being on the safest BTK inhibitor, regardless of mechanism of action, covalent versus non-covalent BTK inhibitor, is going to provide them with the highest quality of life and the lowest, side effect profile. There might be a place for pirtobrutinib for that niche population. But in terms of bleeding, unfortunately, it's performing similar to covalent BTK inhibitors.
Got it. Okay, well, this serves as a perfect, I think, introduction to our next topic, which is Dr. Ma, who's going to take a deep dive into optimal management of adverse events related to BTK and BCL2 inhibitors. Sure.
All right, thank you, Jeremy. Okay, so my focus will be reviewing the adverse events with the BTK inhibitor and BCL2 inhibitors. I think the cases we discussed actually really is a really good introduction to let us to think about how we can safely use these agents. We have learned a lot about the efficacy, but when we're selecting the choice of treatment, we have to take safety into consideration. So for BTK inhibitor, of course, we know there are a number of different potential risks, but of those, the most concerning ones were the bleeding risk and the cardiovascular risk. And for BCL2 inhibitors, the most concerning one is the tumor lysis risk. So first, focusing on the BTK inhibitors. We know that currently there are 4 BTK inhibitors on the market. 3 of them are covalent BTK inhibitors. One is the non-covalent pirtobrutinib. And ibrutinib is our first-generation BTK inhibitor, and zanubrutinib, second-generation, more selective covalent BTK inhibitors. So you can see that their half-lives are quite different. The covalent ones tend to have a shorter half-life, and pirto does have a longer half-life. Another very important difference is their selectivity. Probably that's the most important thing to consider when thinking about the risk of adverse events. Because we know that, for example, ibrutinib not only is targeting BTK, which is our desired target, but it's also targeting some other tyrosine kinases, such as EGFR and such as TEC and other enzymes. And we believe that it's those off-target effects that are explaining some of those adverse events. So here's the kinome map where you can see each dot represents a targeted enzyme. ibrutinib definitely is much less selective. In contrast, acalabrutinib, zanubrutinib, and pirtobrutinib are more selective. So ibrutinib, being the very first BTK inhibitor studied, gave us a lot of knowledge about the BTK inhibitor-related adverse profiles. So this is a updated data from the RESONATE-2 study, where ibrutinib has been used, followed for now about almost 10 years. So you can see that there are various of adverse effects, as we're pretty familiar with, for example, some GI, usually mild GI side effects, some arthralgia, myalgia, but the more important ones, which on the right panel is what we call the AEs of special interest. So they include the bleeding risk and the hypertension, the cardiovascular, in particular atrial arrhythmia. So you can see that most of those adverse events actually decrease over time, but the hypertension actually can potentially increase over time. And for most patients who actually have to stop treatment during this 10-year follow-up, AE is actually the most common reason for stopping treatment, and that accounts for almost 30% of the patients. So knowing that the second generation and third generation BTK inhibitors are more selective, so how do they compare? Actually, Bita has already talked about these studies. I just want to briefly mention those. For example, the ELEVATE-R study directly compared head-to-head acalabrutinib versus ibrutinib. So very quickly, that we do notice that there is an improved safety profile across different categories, such as GI, arthralgia, bleeding risk, and hypertension, and cardiac risk. But there is increased risk of headache with acalabrutinib compared to ibrutinib. So you can see this is a cumulative AFib and hypertension over time. So over time, acalabrutinib definitely has lower incidence of AFib and hypertension. So the parallel study, the Alpine study, compared zanubrutinib versus ibrutinib, focusing on the AE profile. You can see that so most of the AEs are pretty similar between zanu and ibrutinib, except that there is increased risk of infection, COVID-related, on the left, and then on the right, there is significant decreased risk of cardiac adverse effects with zanubrutinib. So again, focusing on the AFib and the hypertension, you can see zanubrutinib definitely decreased the risk of the atrial fibrillation, but there's no difference in the risk of hypertension compared to ibrutinib. So pirtobrutinib versus ibrutinib, this is based on the Bruin study, Bruin CLL 314 study. So all of those are, the previous studies were in relapsed refractory CLL, and the Bruin study actually included both treatment-naive CLL and relapsed CLL. So I wouldn't go into too much detail, as Bita had already talked about it, but there is definitely improved, reduced risk of hypertension and cardiac, but the bleeding risk is pretty similar. So now let's focus on the specific AEs. Bleeding risk. We learned from ibrutinib and other BTK inhibitors that there is increased bleeding risk across the BTK inhibitors. But what is the mechanism? There has been recent years quite a few studies. This is one of them, basically showing that the BTK inhibitors do inhibit the platelet function. This is an example showing that the ibrutinib actually inhibits the collagen-induced platelet aggregation. And when patients are off ibrutinib for a week, that effect is completely reversed. When they're back on it, you see the reduced rate of collagen-induced aggregation. There are actually more than one mechanism how BTK inhibitors might increase the risk of bleeding. And some of those risks are on-target effects. It's because of the BTKs. For example, the GP6 related platelet aggregation, that is an on-target effect because of the BTK inhibition. But there are also off-target effects, so there is a complex issue. So definitely remind your patient they have to hold the BTK inhibitor for 3 to 7 days before and after any invasive procedure. And definitely there's an increased risk of bleeding when you're combining a BTK inhibitor with other antiplatelets and anticoagulants. We would avoid the concurrent use of BTK inhibitor with dual antiplatelet agents or warfarin. In fact, in all of the BTK inhibitor studies, warfarin is excluded. So cardiovascular risk, so you can see across different BTK inhibitors, the incidence is a little bit different, but it's definitely a class effect. So looking at this guideline, this is a guideline that's published recently in the Journal of American College of Cardiology. It gives actually very detailed guidelines on the risk of BTK inhibitor, how to manage those. So here are some risk factors associated with higher risk of patient developing cardiovascular toxicity with ibrutinib, such as older age, male sex, valvular heart disease, hypertension, uncontrolled hypertension, presence of cardiovascular disease, and heart failure, ventricular arrhythmia, pacemaker, and also any left atrial abnormalities. So before starting patient, I definitely take a very detailed personal family history, clinical assessment, checking their blood pressure. I would usually do a baseline EKG and probably echocardiogram to see if there's any structural issues. And I would avoid using the BTK inhibitor for a patient with personal family history of ventricular arrhythmia, because that's the most concerning, life-threatening one. And for a patient who has uncontrolled hypertension, it's definitely uncontrolled hypertension itself is a risk factor for developing atrial and ventricular arrhythmia. So hypertension, definitely have patient monitor the blood pressure, and is ideal to control the blood pressure below a certain safety threshold. And then for patient with AFib, AFib is mostly commonly detected through your clinical exam. So listening to the cardiac rhythm during the follow-up, and also ask our patient to look out for the symptoms. I wouldn't go into details, but just want to show you in that guideline, there are some very detailed tables on how to manage, for example, new onset AFib. Helpful reference. And then some other side effects, for example, cytopenias. I do want to point out neutropenia can occur, and it is definitely okay to use growth factors, both in case of BTK inhibitor and for BCL2 inhibitors. GI side effects, mostly supportive care. Headache, especially with the acalabrutinib, usually it's an early mild headache, and typically taking some caffeine and, if necessary, acetaminophen in the morning will usually relieve that. And that usually pass after the first week or two. Going to BCL2 inhibitor, so we kind of mentioned before, venetoclax, because it turns on the apoptotic machinery, very rapidly you can see reduction in the lymphocytes within a matter of hours, and with that you can see increase in the markers of tumor lysis. So this is a very rapid phenomena, and that's why based on the previous clinical trial experience, we came up with this 5-weekly dose ramp-up schedule, and it's critical to, before starting treatment, to assess your patient's TLS risk. And this is based on their absolute lymphocyte count and the bulk of the lymph nodes. So based on that, you can determine if they're low, medium, or high risk. So high-risk patients are a patient who has any single lymph nodes greater than 10 centimeter, or the combination of over 5 centimeter lymph nodes plus over 25 ALC. So those patients will require inpatient monitoring, and those low and medium risk patients can be monitored outpatient with specific tumor lysis monitoring time points. So very, very important to have post-dose TLS labs monitored. I include a slide. I wouldn't have time to go over that, but you can look at that. This is a very specific example to run you through how to use those guidelines for tumor lysis. The combination therapy, I would say there is probably some increased risk for GI adverse events because both class of drugs can potentially cause diarrhea. But with the second generation, is actually much lower risk. And in fact, the cardiac risk with the combination of BTK inhibitor, second generation BTKI, and venetoclax is very similar to just second generation BTKI by itself. And the triple therapy definitely increased risk of neutropenia and increase of risk of infection. All right, I'll stop there.
Great, thanks, Dr. Ma. Let's go back to the community and hear a case from Dr. Apuri.
Dr. Apuri provides care for a 74-year-old woman with an interesting complication of CLL.
Initially, when she came to me, she was asymptomatic except for lymphocytosis. So I monitored her for over a year. And all of a sudden, she presents to the ER, reporting progressive shortness of breath. Initially, we thought it was a pulmonary embolism, only to find out that she developed a pericardial effusion. So she did have a pericardial window. We looked at the cytology. It described marked lymphocytosis, and we could not identify any other cause of her pericardial effusion. She did very well initially with the obinutuzumab and the venetoclax up until the 200 milligram dose. And after that, she was just not able to handle the ramp up from 200 milligrams to 400 milligrams. That's really when she started struggling with the worsening fatigue and the cytopenias. She developed multiple recurrent urinary tract infections, and she was treated with multiple antibiotic regimens. I always struggle with this in my practice. I understand that IVIG is not standard of care when the immunoglobulin level is greater than 500, which is why I did not offer that to her. But in retrospect, I would like to know what the experts would do. Do they use the recurrent UTIs as a criteria? How often do they use GCSF in these patients? And we always talk about prophylactic antibiotics in acute myeloid leukemia, not so much in CLL. And I would like to know what would they recommend. So she has done very well. She finished her year of treatment 3 months ago. We did a MRD and we also repeated a bone marrow biopsy only because, her counts were not recovering as how I wish that they would recover. There is no evidence of CLL or residual disease. I would like to know how often do they check for the MRD status going forward? And what would they do if the MRD status was still positive?
So Maz, we'll start with the side effects because that's what Dr. Maz just been talking to us about so beautifully. So you've got this patient, they're running into serial infections, mostly UTIs, their IgG level is over 500. When do you think about IVIG replacement? When do you support with GCSF?
Well, I start with GCSF. I think that's a very important part of venetoclax treatment, especially during the ramp-up. Many patients will have some requirements, and that goes away with the subsequent cycles. So that's the relatively easy part. For IVIG, the quality of data in general for CLL to me, is questionable. So it's not my practice to, in general, use it. But for patients who have infections that are otherwise unexplained, and you have a patient with an immunocompromised state, I don't know if the 500 cutoff would necessarily be something that would stop me from giving the IVIG. I mean, these are polyclonal antibodies, and the question is, yes, you may have the number, but are they effective against the infections that are causing problem? We're learning from the myeloma colleagues that, they're being very liberal in a different setting in the bispecific antibodies, regardless of the number. So in cases or patients like this, and if I feel that, I'm doing my best and we're treating the underlying cause and relatively, safe intervention, I would not let a 500 number stop me from using it.
And Bita, what about prophylactic antibiotics? Do you prophylax against pneumocystis antiviral with patients on venetoclax, with patients on BTK inhibitors, or is it tailored to the patient's risk factors?
So the short answer is tailored to the patient's risk factors. With BTK inhibitors, the hope and premise of BTK inhibitors is eventually they're going to cause immune modulation and they're going to improve patients' immunity. So I don't, automatically do antimicrobial prophylaxis unless there is an indication for PJP prophylaxis. If they've been on prednisone, they have another reason to be on prednisone 20 milligrams or higher doses or equivalent for basically 3+ weeks, that's a reason to consider PJP prophylaxis. And for venetoclax, I will see how they do. Particularly, I try to avoid antifungal prophylaxis because then there is going to be drug-drug interaction and it'll affect the ramp-up. If their absolute neutrophil count is less than 500, I consider adding basically antibacterial prophylaxis, but it's a fluid decision, and I just try to see how they do in terms of cytopenias. But I do not automatically put people on PJP prophylaxis and antifungals and antibacterial with either basically venetoclax or BTK inhibitors.
And John, shifting gears a little bit back to the CLL management itself, and I'm not going to ask you what you do. Maybe I'll come back and ask you that. But I'm going to ask for Dr. Apuri and say, Dr. Apuri says, I'm putting this patient on fixed duration therapy with venetoclax and acalabrutinib. Do I need to check MRD at the end, and what do I do with that information?
Yeah, so I think it's a very relevant question. currently, all of the data that we showed you, while MRD was checked, in these fixed duration approaches, it is not used in terms of determining how you manage the patient. And so it is a prognostic factor that will help guide your education of the patient at the end of treatment, when you might need to do something, et cetera. And it is a valuable tool, and you can use it to make decisions, et cetera. But when it comes down to it, it doesn't really need to be done, because these are fixed durations, they're set for the 1 year, and the outcomes are based on what that is, and we've seen that as outcomes. Importantly, in the low-risk patients, actually, they have seen with I plus V from the GLOW study, which was I plus V versus chlorambucil obinutuzumab, in older patients, actually they looked at the lower-risk patients, and those who are MRD positive with mutated IGHV versus those who are MRD negative, at about 4 years of follow-up, actually there was no real difference in the outcome. And so there are subgroups where it may not even matter, the MRD status. For higher risk patients, I think it's going to be a prognostic factor. I do use it. I do think it's important, but it's not something that you have to absolutely have if you're going into this knowing we're going to do the 1 year of treatment. And particularly the VenG approaches, the vast majority of people in CLL 13, which is younger groups, close to 90% of patients are MRD negative at the end of the treatment. In CLL 14, which is an older patient population, close to 75+% of patients are MRD negative. So you can infer that they are there. And so it's not needed, and it's a prognostic factor. And it can provide information, but I think if it's going to confuse you or complicate how you think about the patient, then you're not doing any harm by not having it available to yourself or to the patient.
So sure, let's say John likes checking MRD, and he checks it at the end, and he likes it to come back undetectable, and he gives the patient a high five. But then he calls you on the phone, and he says, Dr. Ma, I really did it this time. I checked MRD at the end of their treatment. It came back detectable. What do you think I should do about it now?
Right. So that's a very good question, and that's an unanswered question, but there is actually an ongoing clinical trial, the MAGIC study, led by Matt Davis, that's trying to answer the question whether using an MRD-directed approach, which means that if you, at the end of 1 year treatment, you have a positive MRD, does extending the treatment to 2 years help to help the patient outcome? So there's a study that's randomizing patients after 1 year to see if it's actually a randomized study of acalabrutin plus venetoclax versus venetoclax plus obinutuzumab. For each of those arms, if patient is MRD positive, they will have a 2 year treatment. If they're MRD negative, after 1 year combination, they'll stop there. So we can see how that data turns out to compare to the standard 1 year treatment. So the short answer is we don't know quite yet. But even though in real life, if I had a patient that's still positive at the end of the 1 year treatment, I might consider extending the treatment.
You talk to him about it. Mm-hmm. Well, let's bring up Dr. Shadman. Mazyar, talk to us about sequencing all of these exciting regimens in relapsed refractory CLL.
Okay, so let's talk about the relapse setting. And my first and last slide are basically the same, so I'm not going to spend much time on it now, just to show you that it depends. Right? The relapse setting options depend on what patients had in first line or in prior lines of therapy. So what I'll do in the next, hopefully 7 minutes, I'll go through a number of studies, kind of one slide per study, because many of them are already covered today. So just a few take-home points, then we'll hopefully spend some time on this slide at the end. And we'll talk about BTK inhibitor monotherapy, covalent, non-covalent BCL2 inhibitor-based therapy, and some of the new upcoming BTK targeting agents in a table, basically. So we looked at ELEVATE-RR, ACALA versus ibrutinib in the relapse setting, patients with del(17p) or 11q, a non-inferiority for primary endpoint that was reached, hazard ratio 1, no difference in terms of efficacy, but a better safety profile for ACALA. ALPINE is a study that looked at Zanu versus ibrutinib. It showed non-inferiority, but also superiority. And as you see here, at the 36-month, you have a superior PFS for Zanu over ibrutinib, both for the entire study population and also in a predefined endpoint of high-risk patients. safety profile was also in favor of zanubrutinib, except for hypertension, where there was a report of same rate for hypertension. So the question of Zanu versus Acala is always interesting. For me, in my clinic, that's all I need to present to the patient, and that decision is usually made based on that. There is a long list of indirect comparisons for more academic-focused discussions, but I think in my experience, the efficacy signal is always something that patients value. And we're looking at patients who received a line of therapy before, and these days that line of therapy is not chemotherapy. So the two studies that I showed you, they're looking at BTK inhibitor in patients who did not receive venetoclax-based therapy. How about patients who these days receive ven-based and now need a BTK inhibitor? What's the data? The quality of data is a little bit less, I would say, solid. There's no prospective study. This is a report from the Australian group now 6 years ago, basically showing that BTK inhibitors are still effective. If patients have short response to ven-based therapy, maybe there's something about the disease biology and there's some signal of maybe an inferior efficacy, but overall this remains a very relevant class, a covalent BTK inhibitor class for patients after prior treatment, including venetoclax-based therapy. Now, in patients who are previously BTK inhibitor exposed, we have the Bruton trial that led to the initial approval of pirtobrutinib. These are patients who are heavily pretreated. The median prior lines of therapy was 3, ranging 1 to 11. These patients, 100% of them had BTK inhibitors, covalent BTK inhibitors in the past. 45%, I believe, had BCL2 inhibitor exposure. And you see that pirtobrutinib works, but the curve kind of goes down, so a very reliable option, maybe not a destination therapy, especially for patients who are also exposed to BCL2 inhibitor, because the median PFS there is around 20, let's say around 2 years, but the relapses seem to be happening over time. A more recent study, the Bruin 321, this was a randomized study that looked at pirto versus investigator choice of bendamustine rituximab or Idela rituximab. Again, here we saw the superiority of pirtobrutinib, the same type of shape of the curve. This study led to the approval of pirtobrutinib in patients with prior exposure to a covalent BTK inhibitor. So you no longer need both BCL2 inhibitor and a BTK inhibitor to be able to use pirtobrutinib based on the new label. This curve shows time to next treatment or death, so it's not PFS, but basically indicating the efficacy of pirtobrutinib in patients who were either, again, everybody is covalent BTK inhibitor exposed. The left panel shows venetoclax naive, and the right side shows venetoclax treated, effective, and kind of durable. Again, this is not PFS, time to next treatment or death, but again, pirto is established as a treatment post-covalent BTK inhibitor. A very important recent presentation at ASH, they combined the data from both studies and looked at patients who received pirtobrutinib after first-line covalent BTKi. And the features for these 37 patients in terms of disease-specific features and kind of some of the high-risk features, exposure to, again, 100% covalent BTKi, majority ibrutinib, and some Acala, and 8% Zanu. And most of these patients, 57%, had progressive disease from the covalent BTKi, and 35% stopped it due to intolerance. Again, this is both PFS and time to treatment, showing that even patients who receive pirto at second line after a covalent BTK inhibitor, I think these curves look better than the prior ones, but still there is a median, and it's in the range of, depending on which one you look at, somewhere between 19 to 30 months. So that's for our non-covalent BTKi after first-line covalent BTKi. I don't want to spend too much time on the resistance mutations. I think it's an important topic that is being looked at in clinical trials. I don't personally use this information for clinical decision-making, except for very rare situations. So we know that patients who have progressive disease after BTK inhibitor, including ibrutinib, are more likely to have C481S mutation. With Zanu and Acala, some of the other mutations show up. Some of those new mutations are shared with pirtobrutinib resistance mutations, and there was this very interesting discussion in the past 2 or 3 years about, okay, should that impact our choice of BTK inhibitor? Over time, we are learning that the percentage of these mutations that are reported are changing, and we have patients, at least I have patients, I'm talking to colleagues who have mutations, and a drug should not be working based on the mutation, but guess what? Patients are benefiting from these treatments for over a year. So I don't exclude these options yet based on the resistance mutations, but I'm sure we'll learn more, and at some point there will be part of our decision making. So moving on to BCL2 inhibitor-based therapy, this is Murano. This is a study in the relapse setting comparing ven-rituximab versus bendamustine rituximab. Now this is the final report. Less relevant to today's practice because these patients all got chemotherapy and then got ven-rituximab. Also from first-line studies, we learned that obinutuzumab is a better antibody than rituximab. So in practice, most of us, if we can get it, we use ven plus obinutuzumab and not rituximab. However, you see the 7-year PFS of around 23% from ven-R. There is an overall survival benefit of ven-R over bendamustine rituximab. The part in the middle of the right part of the slide is very important. It basically shows that when you look at patients who achieved an undetectable MRD, look at the time between MRD from having that MRD undetectable status to appearance of MRD disease, it's 19.4 months. 28 months is the average time from MRD appearance to clinical progression, and 4.5 months from having a clinical progression to having indication for treatment. So if we acted on MRD only, we're over-treating a number of patients just because their MRD showed up, but clinically these patients, if you add up these numbers, somewhere around, I think, between 2 or 3 years of these patients just living their life without having treatments. I thought that was one of the important findings from this study. So ven-R in the post-chemo setting. How about ven-R in the post-novel agent setting? This is from the CORE registry, which an academic collaboration between a number of studies internationally. We looked at the data with ven-based therapy after covalent BTKI. Oh, only have 1 minute. Okay. So basically, it works, and the numbers are here. Median PFS is 30 months. Can you retreat with venetoclax? Short answer is yes. This is a review paper just got published 2 days ago in Blood Advances, and a number of studies I've looked at, including a prospective study called REVEN-G, and that will be updated. So in patients who had a reasonable first remission from the ven-based therapy, you can repeat it. This is a kind of a practical point in patients who are labeled as double refractory disease, meaning that covalent BTKIs are out as an option because either patient progressed on them or didn't tolerate any of them. And also BCL2 inhibitor class failed the patient, meaning that venetoclax or sonrotoclax, when available, are not an option. Those are the patients that these days we start on pirtobrutinib if they haven't seen it. And the clinical recommendation is to refer them to cell therapy consultation when pirtobrutinib is still working. Because when disease progresses on pirtobrutinib, it's very difficult to manage these patients. So the timing of referral is not when pirtobrutinib fails the patient. There's an important study that we learned about the results on a press release, so hopefully soon we will see the data and maybe an approval. This is a Bruin 322 study, a randomized trial in the relapse setting comparing ven-rituximab, which was the investigational arm from Murano, versus pirto-ven-rituximab for PFS as primary endpoint. This is an extremely important study for many reasons. Number one, it could change the standard of care practice in the relapse setting. Fixed duration options in the relapse setting is an unmet need. We don't have many of those or any of them other than ven-R really in the relapse setting. Number two, these patients are heavily BTKI treated in the first line, so it gives us a good understanding of ven-R performance and PVR performance in the post-BTKI setting. And the third importance of this study is that this sets up a new benchmark for our relapse studies. A number of new drugs are trying to beat ven-R, and the estimates are coming from Murano or a bunch of retrospective studies. I think this study provides a very good estimate for the benchmark and hopefully eliminates ven-R as a control arm. Nemtabrutinib is another non-covalent BTK inhibitor, not as clean as pirtobrutinib and also not approved yet. The randomized study, Bellwave 010, is looking at nemto-ven versus ven-R. So the difference here is that you don't have rituximab. It's an all-oral combo versus ven-R. This study is not reported yet. We also have Celestial RR-CLL, so this is the Celestial in the relapse setting. Sonrotoclax, as you know, is a BCL2 inhibitor that's recently approved for mantle cell lymphoma as monotherapy, not approved for CLL. So this study is looking at sonroto-obino versus sonroto-rituximab versus then you have the arm of sonroto-obino, and then there's an MRD-guided kind of treatment after that. So it's important relapse study. And just one, I just skipped this. This was a trial that we have at Fair Touch. I don't talk about it. Well, maybe why not? So nemta plus lysocell for CAR T, because BTK inhibitors may help. So we just opened that study. But then the new drugs that are targeting BTK and are not approved and are in development, Rucabrutinib is a non-covalent and a covalent BTK inhibitor. It's kind of a very interesting drug. Data looks pretty good. We don't talk much about it. We'll see. Again, it looks pretty promising, not very different than the other kind of upcoming drugs. Bexobrutideg, and sounds like the BGB16673 has a name too. It's called Tacbrutideg, if I said it right. So Bexo and Tac are also the two BTK degraders that are kind of going head-to-head in the studies, and it would be very interesting to see what's the development strategy. Okay, I promise to go through this maybe 1 minute if I can, or no. So you will have the slides to look at them, and thank you.
Thanks, Maz. Let's go back to our cases, and we'll go to the community and hear about a case from Dr. Rudolph.
Patients on single-agent BTK therapy typically have many years on treatment, and Dr. Rudolph has a very vibrant, active 83-year-old man who received acalabrutinib for 5 years before the disease progressed.
He tolerated treatment with acalabrutinib extremely well, except he had significant superficial ecchymosis in both his upper extremities, likely precipitated with his avid golfing. His white count and absolute lymphocyte count, interestingly, never really normalized. It was chronically elevated. His total white count settled around 12,000. His absolute lymphocyte count was 8,000. And 5 years into treatment with acalabrutinib, he once again developed worsening leukocytosis and lymphocytosis. At this point, it had doubled within a 4-month period. So I checked him for mutations related to acalabrutinib treatment, and sure enough, he had C481S mutation, prompting me to switch his treatment to pirtobrutinib. He continues to remain on treatment. At this point, however, despite being on treatment now for 10 months, his total white count and absolute lymphocyte count continue to rise. This is unusual because normally we will see a rise in the counts and then a drop. However, as of his most recent count, his white count is now 72,000 and absolute lymphocyte count is 52,000. Ironically, however, his hemoglobin has improved. It's now 13. His platelet count has also significantly improved. It's now 100,000. And his CT scan, most recently done 2 months ago, showed decreasing size of lymphadenopathy. My worry is with his leukocytosis and lymphocytosis, and really a question for the investigators is, when should you start seeing a drop and or normalization of white count and lymphocytosis once you start someone on BTKI?
Any questions for the faculty?
Are there any situations where you might prefer to use pirtobrutinib first line versus covalent second-generation BTK inhibitors?
So, Bita, this is a funny case. This patient's anemia is getting better. His thrombocytopenia is getting better. His nodes and spleen are shrinking. And 10 months in, his ALC is still rising. Is that typical, and what would you do?
Yeah, I would encourage patients. So if the patient is feeling well, and if we have objective data that lymph nodes and spleen are shrinking and the hemoglobin and platelet counts are improving, there is no basically one-size-fits-all for normalization of absolute lymphocyte count. I would assume that is basically those are deactivated lymphocytes. Yes, 10 months is an outlier, but I would, I need more data points to make a definitive decision. And in general, I don't have a purely numerical approach to CLL. If a patient clinically is feeling well and this patient objectively on radiographic data is improving and they have PR with persistent lymphocytosis, I would just continue their current line of therapy with the very knowledge that probably this patient will need another line of therapy, and what that's going to be in an 85-year-old is a question to discuss. But normally, in the majority of patients, 6 to 12 months after initiation of covalent or non-covalent BTK inhibitors, you do expect normalization of counts, if not sooner.
And John, I think, Maz put up the schema for CLL-322, Bruin, with PVR. Where do you think that's going to fit in the relapse refractory setting?
Yeah, so I think it's going to be very relevant. If I have a patient that's BTK mutated, progressing on their frontline BTK inhibitor, and is otherwise fit and eligible for a venetoclax-based approach, I tend to favor using a venetoclax-based approach. There are many patients, though, in fact, that I use pirtobrutinib and venetoclax combinations. And so I think this kind of fixes the problem of, is this patient progressing or not? Because a ven-naive patient that's on pirto, but it's also going to be getting, let's say, PVR, that white count's going to go away. Those nodes are going to respond. It's going to take this clinical conundrum kind of away. And in fact, we don't really know, but there's hypotheses that if you can eliminate the BTK mutated clone by getting them MRD negative, we don't really know, but possibly a different clone that's not mutated may grow back, and it may reestablish our ability to cycle these drugs again. And so I think there's going to be a lot of use of this. It proves that it's meeting its endpoints, and I do think it's going to be a relevant approach in an otherwise VEN-eligible patient. I think an 85-year-old, I think it's still going to be complicated to do that, and I think there's going to be those cases where you are older and you have comorbidities and you're not quite the VEN-R ramp-up type of patient or managing the antibodies. But I think your general progressor that's in their 70s, that's been on ibrutinib or Cala for 8 years and finally progressing, I think that's going to be kind of the regimen. And it will offer them a fixed duration finally after this, nearly decade of treatment. Finally, they can get a holiday and get off of therapy and potentially be off it for many years.
Sure. We saw in Maz's presentation that a patient who's going on pirto after being double refractory, probably not going to have a long-term remission, and that's when they should probably be referred to think about CAR in the near future. Let me ask you this. Let's say Dr. Aparna has a patient who's starting to progress on their pirtobrutinib, and she says, geez, I should probably send this patient in for a CAR. Should Dr. Aparna stop the pirtobrutinib and send them in for a CAR evaluation, or should the pirto be continued while they get evaluated for CAR?
So that's a very, very important point, is do not stop the BTK inhibitor if your patient is progressing until you have an established response to the next treatment. Because we know that patients who are actually progressing on the BTK inhibitor, once you stop it, they're going to accelerate. So even though they're starting to develop resistance, it's a kind of a gradual resistance, the BTK inhibitor is still trying to hold the leash a bit. But once you let the leash go, then the horse will really accelerate. So that's going to make things much more difficult, especially if they're going for CAR. Remember, going through CAR is a process. So getting insurance approval will take a few weeks. Once they collect the T cells, the production will take about a month or so. So there's going to be almost a 2-month of waiting period. So you definitely want to make sure the disease is not accelerating. Even if they're progressing slowly is fine. But do not stop the BTK inhibitor. And then the other learning point is that I definitely agree with Mazyar that I would not wait until patients actually progressing on the pirtobrutinib to refer for the CAR T, because once they start to progress, they can become very refractory and really accelerate. Even if you don't stop the pirto, there's a very short window that you can actually rescue the patient. So it's actually better that if your patient's already double refractory to covalent BTKI and the BCL2 inhibitor, when they're on the pirtobrutinib, that is the time you should refer them to the referral center to consider CAR T, so we can have time to prepare the patient.
And Maza, 1 second answer to the question, is there a patient today, with the data you have today, that you use pirtobrutinib ahead of a covalent BTK inhibitor in a treatment-naive patient?
1 second would be no. I don't think there is any evidence to show that pirtobrutinib has a better safety profile compared to second generation. And so until we get that, I would not do that.
All right, let's go to our final module, and we've hinted at all of these newer treatments, and let's think a little bit more about these newer treatments that are going to be foundational for the future of CLL. And I want to start with talking about Liza-cel, the only FDA-approved CAR T-cell for CLL. This is based on the Transcend CLL study using lisocabtagene maraleucel, or Liza-cel. This study looked at 118 patients. These were heavily pre-treated patients with a median of 5 lines of therapy and up to 14 prior lines of therapy. Those really were heavily pre-treated patients, high proportion of p53 aberrations. All of these patients had seen a prior BTK inhibitor. The majority of them had seen both BTK and BCL2 inhibitors, and the majority were refractory to both drug classes. So most patients in the study really did represent this really poorly met medical need today. If you look at the 88 responsive evaluable patients, about half of them responded. The CR rate was kind of a disappointing 20%. Although we heard earlier from Dr. Allan that the IWCLL response criteria don't always truly capture the depth of response. And in fact, if you look at the MRD rates using MRD4, in fact, 66% of patients went MRD undetectable in the blood, and 60% went undetectable in the bone marrow. So these patients really could have deep remissions even with heavily refractory disease. And the median progression-free survival was 1.5 years, which, given how refractory these patients were, is fairly encouraging. If you look at those patients who did have a CR, you can see in the red line that their progression-free survival was remarkably durable. And if you look at the lower right-hand panel, you can see that the MRD undetectable patients actually had a median progression-free survival of nearly 3 years, and that was the majority of patients. Remember, 2/3 of these patients were MRD undetectable in the blood. So Liza-cel could induce durable CRs, or durable remissions, I should say, in a significant proportion of patients. I'll make one note about the toxicity, which is we typically see more CRS and ICANS in CLL than we do in something like diffuse large B-cell lymphoma, probably because these patients have a lot of circulating disease, high tumor burden in the blood and the bone marrow. That typically increases the incidence of CRS and neurotoxicity. But importantly, most of it, even in CLL with Liza-cel, was low grade, with very uncommon cases of grade 3 and higher CRS, which was less than 10%. Grade 3 and higher ICANS was only 20%. Now, interestingly, if you combine ibrutinib with Liza-cel, it appears to enhance efficacy. And these are uniformly patients who've already received a BTK inhibitor. In these patients where ibrutinib is added to Liza-cel, we now see a CR rate that goes up to 45%, and we see an MRD undetectable rate in the blood that goes up to 86%. So these numbers really look quite favorable compared to Liza-cel monotherapy. Now, we've already said we're not really giving ibrutinib anymore. We're giving next-generation BTK inhibitors. So it's important to note that it might be working a bit differently in the setting of combining with a CAR T-cell. And it's possible that some of the magic, if there is magic in this setting, might be due to off-target effects, not just BTK. So there are other studies ongoing right now looking at other BTK inhibitors with CAR T-cells, and it'll be interesting to tease apart whether we see these same benefits with next-generation BTK inhibitors. But I do think this is a reason to consider a combination for a patient who's getting a BTK inhibitor with continuing it in concert with their Liza-cel. Now, another really tough situation is Richter's transformation. We haven't talked a lot about patients who have large cell lymphoma arising out of CLL, but we know this is a tough nut to crack. We do have some CIBMTR data that looks at patients who got Liza-cel, specifically in the context of Richter's transformation, and the take-home message here is it works pretty darn well. These are high-risk patients. All of them had already gotten chemoimmunotherapy for Richter's transformation, and yet the overall response rate was nearly 80%, and 2/3 of patients achieved a complete response, which is analogous to what we would expect in a de novo diffuse large B-cell lymphoma in the relapse refractory setting. Here we're seeing it in a Richter's patient. The PFS, you can see here, was durable. We only have a relatively short-term follow-up. At a year, you can see just over half of patients remain progression-free. So I certainly do consider CAR T-cells for my patients who've already received chemotherapy and need another line of therapy for Richter's transformation. Liso-cel is my treatment of choice. Now, Liso-cel is not our only T-cell engaging therapy. We know that bispecific antibodies are the bee's knees and the cat's pajamas in the lymphoma world right now. And so we're thinking about where bispecifics fit in the setting of CLL, but unfortunately we have less data than we do in other lymphoma histologies. Here's what we do know. This is epcoritamab. This is a CD20, CD3 subcutaneously administered bispecific antibody given to all of 23 patients with relapsed refractory CLL. Now, these were heavily pretreated patients with a median of 4 prior lines of therapy for their CLL, and 2/3 of them had a TP53 aberration, so these were high-risk patients. The overall response rate was 61%. Nearly 40% achieved a CR to epcoritamab monotherapy, and if you look at their progression-free survival, the median PFS was just about 1 year. So the median PFS maybe isn't quite as good as the median PFS we saw with Liso-cel, but this is an off-the-shelf product able to be given without collection, lymphodepletion, chemotherapy, etc. And so this is an appealing option for that heavily pretreated patient who's already exhausted their BTK inhibitors, BCL2 inhibitors, potentially pirtobrutinib, and we're looking for other options. What about Richter's transformation for the bispecific antibody? Well, EPCO was also looked at in Richter's. This is a 42-person study. This was just published in Lancet Hematology just a few weeks ago. And what you can see in these Richter's patients, the overall response rate was 48%. 40% of patients achieved a complete response. The median duration of response was okay, but not great at 10 months. But the median progression-free survival in the overall population, not very good at 3 months. So I would say based on this, if I were to have my choice of options, I'd be reaching for Liso-cel. In my Richter's patient, it doesn't look like the bispecific antibody based on this data is giving us quite the same bang for our buck as a CAR T-cell in this large cell lymphoma histology. Now, there are other bispecific antibodies in development. This is surovatamig. Surovatamig is unlike the other bispecific antibodies we currently have approved for lymphomas because this targets CD19 instead of CD20. And in developing surovatamig, we have limited data in CLL, but that isn't stopping AstraZeneca from thinking about a randomized control trial. And what they're saying is, you heard data earlier that patients who get fixed duration therapy and are IGHV unmutated tend to progress sooner once they stop their fixed duration therapy. And so what this randomized trial called Soundtrack C1 is going to do is it's going to take patients with IGHV unmutated disease who respond to fixed duration frontline therapy and then randomize them to surovatamig consolidation versus standard of care observation. And we're going to see if in this higher risk subgroup, if consolidating their remission after frontline fixed duration therapy might have an added benefit and create a nice niche for bispecific antibody therapy. Now, we've heard about other drugs targeting BCL2 and BTK today. You heard about sonrotoclax, which most recently got some flashy press because it got its first FDA approval for relapsed refractory mantle cell lymphoma. It is 14 times more potent than venetoclax. It's more selective than venetoclax by targeting less BCL-XL, and it has a shorter half-life. And you already saw there's some early appealing combination data combining sonrotoclax with either obinutuzumab, zanubrutinib, or both. And that ongoing randomized trial is going to really try and tell us where sonrotoclax is ultimately going to fit in in the management of relapsed refractory CLL. Right now, of course, we don't have data to tell us that sonrotoclax has a niche just yet, but multiple ongoing studies, I think, are going to tell us that this is an appealing drug and has some appealing pharmacokinetic and pharmacodynamic advantages over venetoclax. Will that translate into true clinical benefit over venetoclax? I think we're going to need some randomized trials to tell us that. What about these BTK degraders that you just heard about a few minutes ago? Well, the potential appeal of a BTK degrader is overcoming resistance-specific mutations that prevent binding of either a covalent or a non-covalent BTK inhibitor. Because instead of those drugs, the BTK degraders are going to target BTK for proteasomal degradation, and so shouldn't be dependent on the binding mutations to BTK. So this is BGB 16673. This was studied in 68 patients, pretty heavily pretreated population with a median of 4 prior lines of therapy. Over 2/3 of them did have a TP53 mutation. So these were high-risk patients, and 90% of them were refractory to a BTK inhibitor already. The overall response rate, despite being BTK refractory, was 85%. And what you can see below that overall response rate is that whether you look at P53 mutation status or BTK mutation status, that their overall response rate was high across the board, independent of their baseline mutational substructure, suggesting that this is working as we would expect it to, which is potentially mutation independent. And the progression-free survival is really, I would think, remarkable for a BTK refractory population. Shown here, a year and a half, 70% of patients remain progression-free on BGB 16673. What about bexabrutideg? Does anybody think that bexabrutideg sounds like a cross between Beto O'Rourke and Pete Buttigieg? Bexabrutideg. Bexabrutideg is a BTK degrader as well. 126 patients, also refractory with a median of 3 prior lines, maybe not quite as refractory, 40%, maybe not quite as highly mutated in terms of P53, but nonetheless, an overall response rate here of 83%. That was once again mutation independent on that forest plot, and a median progression-free survival of just about 2 years. So these BTK inhibitors really, I think, are showing us that they offer functional advantages over conventional BTK inhibitors in patients who are already resistant to covalent and potentially even non-covalent BTK inhibitors. They do have a future. With that, let's go back to the community and let's hear about a case from Dr. Divers.
The final case presented by Dr. Divers addresses another common and important issue in CLL, the patient with high-risk disease.
So this lady was initially diagnosed back in 2009. She did have a 17p deletion. She received 3 cycles of FCR. She had a complete response, moderate amount of toxicity, and sort of at that point washed her hands of the medical community for a bit and disappeared until she returned with a white count of 900,000 and a platelet count of 7,000. She was placed on a number of agents, including ibrutinib and obinutuzumab and venetoclax, with transient responses to all of those and moderate toxicity, mostly in the form of thrombocytopenia. I had a discussion about transplantation and or CAR T. We put her on pirtobrutinib in the setting of pancytopenia, generalized adenopathy, and progression on multiple prior agents. And she really responded beautifully. All of her adenopathy improved. Her CBC returned totally to normal. And then she showed up with, white count of 60 to 80,000 with 80+% CLL cells. She had about 1.5 years or 2 years of disease control. I really thought she had transformed, but repeatedly her flow. And we actually biopsied an inguinal node and still didn't see transformation there. We attempted to get her to CAR T, but unfortunately her performance status declined and she passed away. So we're not used to seeing patients with CLL actually die from the disease anymore. So, the real question here is, in a younger patient like this, when do you escalate to cellular-based therapy so as not to miss that opportunity?
Yeah, Dr. Divers gets to a critical question, which we sort of hinted to at the last presentation, and we can kind of get more into the heart of it now. So Mazyar, let me start with you. With all of these different drugs available, when are you reaching for CAR T cells?
My rule is I refer for CAR T when I still have one standard of care drug that is working, excluding PI3 kinase inhibitors. So right now, if you think about three classes of covalent BTKI, non-covalent BTKI, and BCL2 inhibitors, once I kind of pass two classes and I'm on the third, I think that's the time to think about the cell therapy. Now, let's say near future we have one of the degraders approved, that may change it. The idea is you showed the data nicely that CAR T doesn't work for everyone. So those situations, you need something that you can go on immediately. Clinical trials are always the priority, but patients post-CAR are not necessarily the best candidates for trials. So right now, if I have someone who's, as we showed on Pirto, I would start the conversation. It doesn't hurt to have pirtobrutinib still working, even if CAR T works. You can use it, and there's data from multiple institutions and also the Transcend trial that you can continue safely BTK inhibitor basically throughout the process of even leukapheresis, lymphodepletion, and even later if needed. So yeah, so when the last treatment is working, that's the time to think about CAR.
And so that's great. So Shuo, so if you've got a patient who's now progressing on after both covalent BTK and BCL2 inhibitors, they're double refractory, and you're sitting there deciding between pirtobrutinib and CAR T cells, how are you going to make that call?
Yes. So both of those are in the NCCN guidelines are indicated for patients who are double refractory. I think it's a complicated discussion with the patient, and it depends on the patient, right? If your patient is a really good CAR T candidate, a young patient, high-risk patients, I will consider CAR T early. And you can definitely use Pirto as a bridging to the CAR T. If you have a patient that, CAR T is not feasible because of social economic issues, or if it's because patient has too much comorbidities, you worry about the potential toxicity with the CAR T, then pirtobrutinib is definitely much easier. These are two very different, dramatically different treatments in terms of the feasibility, the tolerability. Pirto, there's no question Pirto is better tolerated. But you have to think about the long term. You have to think about how to plan the treatment so that your patient can have the longest disease control. So for those patients who are not eligible for CAR T, you should think about referring them to academic center for clinical trials, such as the BTK degrader studies or the next generation BCL2 inhibitor studies.
John, let me bring you a question from the universe that came in over Zoom. What do you recommend for a 65-year-old patient with Richter's transformation to DLBCL that transformed while getting a covalent BTK inhibitor? Patient had a CR after 2 cycles of R-CHOP. You're planning for 6 total cycles of R-CHOP. When do you consider CAR as consolidation? Or do you consider an allo transplant for consolidation? Or do you consider a BTK inhibitor for consolidation? Or do you finish out 6 cycles of R-CHOP and cross your fingers?
Yeah, so it's there's not a right answer, and I'm not going to pretend that I will have an answer that I think everybody on this panel would necessarily agree with. Obviously, they're in a CR after 2 cycles. I think with Richter's, we are concerned if it's a truly clonally related, very high risk, classic transformation. The historical answer is to take that patient to an allogeneic transplant if they are otherwise fit and have a donor available and are ready to go and able to do that. And you don't necessarily frequently don't need to take them through all 6 cycles, but honestly, many times you're working them up and it's going to take time to do that, so you're going to continue on the treatment. With that said, I think that CAR T consolidation is an interesting question. I don't know if we have really any good data to say that that's a better approach over an allogeneic transplant necessarily, and I think that's kind of a research kind of question, and I don't think it's a standard necessarily approach to take. With that said, it's intriguing, and I think we need to have that explored and understand it. The last component, though, is kind of interesting. So we have an IAT at a few centers with polatuzumab and EPOC in Richter transformation. And in that study, we did allow maintenance treatment after attaining some CR. You can use any FDA-approved targeted agent as a maintenance therapy. And many of these patients would either they transformed on a ven-based treatment and that were BTK naive, or they had pirtobrutinib. And there are several patients now that achieve CR, maintained on a maintenance therapy, typically a BTK inhibitor, and there's at least 3 or 4 patients that are now 2 or 3 years out, never having transplant, and are still in remission. So, you have to remind ourselves that these are older patients. They aren't typically allo transplant candidates. They typically aren't even CAR T candidates half the time. And I think if you can get them into a CR, it absolutely makes sense to maintain them with some sort of targeted agent after that. And typically now with pirtobrutinib available, most of these patients may not have even seen that, is going to be kind of the answer. Now, if you transformed on a covalent, there are studies looking at, and Dr. Shadman can maybe even speak to that, about pirtobrutinib in combination with the induction. And so I think that's an attractive approach. There's data out there with venetoclax and R-CHOP. And again, I've shown some data with polatuzumab. And
lots more data to talk about, but we are at the top of our half hour. We want to respect everybody's time. So with that as the last word, I want to give a huge thank you to all the wonderful faculty on the stage. I want to give a huge thank you to the general medical oncologist for contributing their cases and their questions, and a huge thank you to all of you in the room and online. Have a wonderful ASCO and good night.